Oh, it's an honor to be back this year, this time talking about masks and other non-pharmaceutical interventions. Today, I'm going to address the question, is it time to return to our pre-pandemic ways? At the recent ID Week meeting in Washington, D.C., Dr. Weston Branch Elliman gave a talk about mitigation measures entitled Context Matters, and I've adapted a few of her slides, including this one. Early in the pandemic, we used a variety of mitigation measures, each of which had a different level of acceptability and variable ongoing degree of individual effort. And while most of them had a moderate to high associated degree of effort, the acceptability was also mostly moderate to high at that point in the pandemic. Note that things like mask mandates and testing requirements were pretty acceptable in the early days, especially as a way to get back into businesses and schools. Because of course, those closures had much lower acceptability, and for good reason. They were harmful. Now, Chambers and colleagues in 2013 wrote about this concept of the dynamic sustainability framework. And in this paper, they addressed what's called the paradox of sustainment amid ongoing change. Here you can see interventions represented as puzzle pieces and context represented as the thing in which you insert your puzzle piece. And that context changes over time. In the case of the pandemic, the context has changed based on new evidence, newly available interventions, different settings, changes in the virus itself, and changes in community immunity. And as we move forward in time, the puzzle piece needs to change to fit the context and to achieve the goal. And I'll argue that the goal has always been to prevent severe disease, long-term morbidity, and death, and that sometimes we forget that goal. Now, new daily deaths from COVID are clearly still too high, but they are steadily improving over time. One question we can ask is COVID-19 still more deadly than seasonal influenza, a disease for which we never mandated non-pharmaceutical interventions like masks and distancing in the past? And the answer is both yes and no. Now, a rather elegant analysis designed to answer this question was conducted in March 2022 by, believe it or not, the Financial Times' John Byrne Murdoch, the chief data reporter, and Oliver Barnes. And they calculated the infection fatality rate, or IFR, for COVID-19 using, for the numerator, death certificates where COVID-19 was mentioned. And that number came from the Office of National Statistics in England. Now, we know that in the earliest days when testing was constrained, we were missing COVID deaths, but we don't think that's a major factor today. And in fact, using death certificates probably overestimates the deaths that are caused by or contributed to by COVID. For the denominator, they used an estimate of total infections generated by models that are produced regularly by the Office of National Statistics in England. And they accounted for the time lag between infections and death. And they got a changing IFR for COVID-19 over time. Then they also calculated flu IFR. They used a combination of US CDC data and prior studies, and they adapted the age-specific rates that they calculated to the English population and got an IFR for flu of 0.04%. And what you can see is that when COVID-19 first emerged, the IFR was almost 20 times that of flu for the oldest age groups, and even a little higher than flu for the youngest age groups. This is somewhat consistent with CDC estimates as well, although CDC had reported a lower IFR for COVID in young children compared with flu. But over time, by March 2022, they show that COVID-19 became less deadly than flu for all age groups and a lot less so for the younger ones. Looked at another way, COVID has grown less lethal on a population level over time, declining precipitously with vaccination, and then again with the massive Omicron wave of infection, dipping below the IFR of flu by the spring of this year. But still, as you can see on the right, COVID killed more people last winter than flu does in a typical winter. Why? Because there is just so much of it. That's because there are two ways to measure how deadly a pathogen is: IFR and crude mortality rate. IFR is the proportion of people who die once infected. Crude mortality rate is the proportion of a population who died of the infection in question. And while the IFR of an infection can fall over time due to immunity from vaccination and from infection, due to improved medical therapies and inherent changes in the pathogen, such as we are seeing with the reduced severity of Omicron compared to prior COVID-19 variants, that does not mean that crude mortality will always follow, since the latter also depends on how many people are infected in a given period of time. So where does that leave us, and where are we headed this winter? Well, in the absence of a new variant with a dramatic increase in immune evasiveness or a change in inherent lethality, we can expect to continue to build that immunity wall. This is the Zero Tracker webpage, a collaboration between multiple health agencies, including the WHO and the Public Health Agency of Canada, among others, and it's updated daily. Here are just a few examples of seroprevalence rates from different studies around the world. Some represent immunity just from infection, others infection or vaccination, but the results are similar. United States, 86.3% in August, Republic of Korea, 99.4% in September, Australia, 99.6% in September, Switzerland, 93.8% in June. Now we can expect our IFR to stay low or even decrease further, and with it, deaths will continue to decrease, again, barring the emergence of a new and more deadly or very immune evasive variant. And we can see the impact of that immunity. Here's a graph of new cases on top with new deaths from the same countries on the bottom. And you can see that with each wave, even if that wave is larger than ones before it, new death curves, for the most part, get smaller and smaller. And that is really something to celebrate. But I think one of the biggest arguments against mandated non-pharmaceutical interventions is the potential unintended and dangerous consequence of what some people have termed immunity debt. Now, immunity debt is not a term that applies to an individual, but rather it's a phenomenon that occurs at a population level. This is a figure in a paper by Messakar et al. In the Lancet, and it shows it well. When you are not taking extreme measures due to a deadly pandemic, a typical year has seasonal outbreaks of viral illnesses like RSV and flu, among others, which you can see here above the line. It also has a waxing and waning size of the susceptible population here below the line as children are born and people become infected. It is mostly those infants and younger children who are susceptible and who become infected. After all, 80% of children contract RSV by the age of 2, nearly 100% by age 3 in a typical year. But in 2020, with stay-at-home orders, closed schools, and masks, infants and young children were not infected by the endemic respiratory viruses. And the next year, those infants and young children became older children who were still not infected. That larger pool of susceptible children is almost certainly what is now contributing to the spike of cases that we're seeing today. So while it's fine for individuals to choose to try to avoid respiratory viruses, I do, attempting to control them on a population level may serve to kick the can down the road further and lead to more surges in the future. Now, on an individual level, people should realize that their risk of mortality from COVID-19 is now on par with or lower than what their risk from flu was, but that their risk of contracting COVID-19 is still higher than their risk of coming down with flu most seasons. We also need to consider that pandemic fatigue is real, and that asking people to do something they're simply not willing to do is a recipe for failure and worse, for loss of trust in public health. This is an interesting study by Briscesi et al. From the earliest days of 2020 in Italy. The researchers conducted a survey asking people about their intended compliance with mandatory mitigation measures. And they asked participants if their likelihood to comply would be affected by their expectations regarding the planned duration of the mandates. And not surprisingly, they found that they would be. That if the mandate were to be extended beyond what was initially stated, the likelihood that the respondents would comply would decrease. But check out the graph on the upper right. Among the subgroup of self-reported highly compliant people, that phenomenon was most striking. I see this so clearly in the hospital as we struggle to get people to do things that are hard, like wearing eye protection or wearing their masks in the break room. And we've had to shift our policy to fit the willingness of our staff to comply while calculating the risk benefit of each of those policies. So here we are in an era today where we have many more ways to mitigate severe disease and death from COVID-19, ones that have high to very high levels of sustainability, like ventilation, vaccination, pre-exposure prophylaxis, which is unfortunately not very effective right now, but will hopefully come back, and effective treatments. That makes it time to completely retire things like social distancing mandates and business or school closures, and to shift things like masking and testing to personal choice rather than mandatory. We now have a supply chain that can support the use of high quality masks like N95s, which were advised against in the early days because we needed to save those masks for healthcare workers. And we know that one-way masking works. Those of us who see COVID patients in the hospital know patients are almost never wearing masks while hospitalized, and we've been safe while caring for them. So as we move into this next phase of the pandemic, we must consider some key principles of public health: engender trust, minimize infringements on freedoms, and maximize sustainability. I like this quote from Inglesby et al. In 2006 in a paper on controlling pandemic influenza. An overriding principle: experience has shown that communities faced with epidemics or other adverse events respond best and with the least anxiety when the normal social functioning of the community is least disrupted. Strong political and public health leadership to provide reassurance and to ensure that needed medical care services are provided are critical elements. If either is seen to be less than optimal, a manageable epidemic could move toward catastrophe. Normal social functioning. I say it's time. So while the effectiveness of the mitigation measures hasn't changed per se, the context has. Of course, we also now have a better understanding of what interventions had the greatest impact, and we know that compliance is going to be key to realizing that effectiveness. Policies that do not require a lot of ongoing effort are likely to be the most effective when it comes to preventing serious outcomes. To sustain effectiveness, policies must be nimble and dynamic. So in closing, is it time to return to our pre-pandemic ways? No way. We need to make some changes. We need paid sick leaves in countries that don't have it so people can stay home and not infect others. We need equitable access to healthcare for both prevention and treatment of disease, not just COVID-19, because the healthier you are, the far better you fare against respiratory viruses and in general. And that includes having a trusted primary care doctor you can talk to when you have questions about your risk and how to mitigate it. We need to make sure that people always have access to COVID vaccines and to testing and treatment and that high quality PPE I mentioned for those who want it. I think we need a viral weather map. People who are high risk should have a way to know how much virus is out there when they're considering going out in public, whether it's COVID, flu, or other pathogens. And with home testing not being reported to dashboards, that's not possible today. Wastewater can help with that effort. And we need to find permanent solutions to the hospital capacity problem. Hospitals can't afford to operate half empty, but then they don't have the ability to flex up capacity when there are surges, and canceling elective procedures is a solution that only worsens the problem down the line by making people sicker. Healthcare workers are burned out and leaving the field. We need to incentivize people to join us in this amazing, rewarding occupation. Hopefully one day our new normal will be even better than our old normal. Thank you.